Welcome back for those of you who joined us yesterday. Wasn't that a great session? I don't know about you, but I learned a lot and I am so excited to take some of the things I learned back to my group and improve our practice and care of our patients. And welcome to those of you who are joining us for the first time today. For those of you I haven't introduced myself to yet, I'm Jamie Letter. I am the nurse practitioner at the University of Pennsylvania with the Interstitial Lung Disease Program, and I'm one of the co-chairs of the Nurse and Allied Health Network.
And my name is Janelle Reichhuber, and I'm a nurse at the University of Kansas Health System and the other co-chair of the Nurse and Allied Health Network. Today, we're going to hear an update on what our working groups have accomplished and are planning for the future. As we mentioned yesterday, we would love for you all to be a part of the Nurse and Allied Health Network. So please feel free to reach out to myself or Jamie through the chat or message functions during the conference or even after the conference. Just send us an email.
We have another great session planned for you today. After our working group update, we're going to hear from Susan about oxygen and legislation around oxygen. We will hear from Charles about ILD specialty pharmacies, and Rebecca is going to speak to us about lung transplant and partnering with our lung transplant programs. We will take a short break, grab yourself a cup of coffee or a snack, and then come back to hear from Chris about pulmonary rehab. Annalise will share about pulmonary hypertension and autoimmune interstitial lung disease. And then Kathy is going to share with us about her research journey.
We will not have a formal question and answer session today, but please feel free to reach out to any of our speakers, Jamie or myself, with your questions and any feedback you may have. We hope you enjoy today's sessions. And with that, let's get started.
Hi, this is Jessica Shore from the Pulmonary Fibrosis Foundation, and I'd like to talk to you a little bit about the working groups that we have within the Nursing and Allied Health Network. As many of you know, I joined the Pulmonary Fibrosis Foundation in November 2020 and really was excited to be able to continue my work with nurses and other allied health professionals to really advance care that is provided to those living with pulmonary fibrosis. So I'm really excited to be able to provide these updates from the working groups to you all. Now, many of you already know that why we're all here in this session. It's Nursing and Allied Health Network, and we're all here just to be able to improve lives of those living with pulmonary fibrosis. And we want to make sure that there's professional development and collaboration across the Nursing and Allied Health Network to be able to improve that care that's delivered to patients. And we're really lucky today to be having Jamie and Janelle here. They are so tireless volunteers for NON and the CCN at the PFF, and we really appreciate Jamie and Janelle and all the work that they have done for the planning of this summit and all of the working groups that they helped to oversee. I'd also like to give a quick shout out to Erin Mahoney, our planning organizing program today, and she was tireless in making sure that the sessions, the 2 sessions that were designated for Nursing and Allied Health Network, were able to really be robust and provide a lot of great educational professional development to all of you today, and the other session that was offered during Summit. So when we think about the Nursing and Allied Health Network, one of the ways that we're able to continue to do our mission is through working groups. And we know that Jamie is working on a new patient handbook, and this is also going to be developed in working with our programs team at the PFF so that new patients have robust information to utilize and be connected, and also be able to share outside of the CCN for patients who may not be able to be seen at a CCN. We have monthly journal club. Lori, you find awesome groups, and this is a time for us to designate every month to be able to review a journal article, get up to speed. We've had some phenomenal presentations. I think of those from Hopkins that provided information about the COVID vaccine antibodies to those who are immune suppressed, particularly those with lung transplant and some other rheumatology issues. Nurse mentorship. So this is getting up and off the ground. Kathy Lindell is providing her guidance, and Erin Rose is offered to assist us and be able to develop out mentorship so that we can really develop out, just not with nurses, but across the scope of practice, to be able to provide great mentorship across the Nursing and Allied Health Network. Erin, I've mentioned, she did an awesome job of being able to bring the summit together for Nursing Allied Health Network. So thank you, Erin. And then Ann Lease, we've been able to continue to build out our research program within the NON, and about 4 of us were able to attend a research intensive seminar this past summer at the Ohio State School of Nursing, and that was really great for us to start building the foundation of additional research that the Nursing Allied Health Network can do. Lastly, another working group that we are in development right now is working on non-position statements. We know the CCN and PFF develop out position statements as needed, and as we hear from patients, care providers, caregivers, and patients alike, all come together to tell us and inform us of what types of position statements, along with healthcare providers. But we really want to listen to what nurses and Allied Health Network would really like in terms of position statements. Are there specific protocols that you use in your clinic that might be helpful to share? Are there educational materials that you use that we could help develop to disseminate across the network? So I look over the next year as a goal to really be developing out that working group with all of you. And that's where I want to end right now with this great update from all the work that was done over the last year, is that there is room at a working group for you. And our working groups are only as strong as many members who participate and provide us guidance and provide that volunteer time to really be able to improve patients' lives who are living with pulmonary fibrosis. Please reach out at any time to me, jshore@pulmonaryfibrosis.org, if you're interested in joining any of the different working groups, or if you have an idea of a new working group. Thank you so much, and I continue to look forward to working with all of you in the coming year.
This is Susan Jacobs. I'm a research nurse manager at Stanford and a nurse coordinator in the Interstitial Lung Disease program there. And I also chair the American Thoracic Society Oxygen Special Interest Group. And today I'll be discussing oxygen and legislation. I have no disclosures. And we'll go through the background of oxygen reimbursement, some of the roles, very important roles that patient and advocacy and professional organizations play, and really where we stand now. This is a large issue. We have 1.5 million oxygen users in the United States, and a lot of these reimbursement changes have really cascaded down and affected patient satisfaction and the services for their day-to-day use of their oxygen. So one of the key issues is reimbursement. And as you can see on this slide, one of the most notable changes was our loss to access to liquid oxygen, just shown here on the left, because it's a very high cost type of oxygen delivery. And we've now, because of the reimbursement system, really lost that option and are dealing more with compressed gas and very cumbersome tanks and canisters. So the change in reimbursement has progressed over the years, and I'll just try and do a brief overview to the historical aspect. The goal of all of these changes was to decrease Medicare fraud and change and decrease the costs of Medicare we're spending on oxygen. So in 1997, there was a Balanced Budget Act that decreased oxygen reimbursement by 25%. In 2003, there was a Medicare Modernization Act, which had another decrease over the next 10 years. In 2004, there was new Certificate of Medical Necessity and exercise testing criteria added, followed by another Deficit Reduction Act with more oxygen cuts. And then between about 2009 and 2014, really saw the onset of competitive bidding as a new type of reimbursement for oxygen. And it basically cut reimbursement to the durable medical equipment companies to the point where almost half of the durable medical equipment companies had to close. So they really reduced the number nationally of DMEs by about 50% as a result of the competitive bidding. So how do you define exactly what competitive bidding is? An interested vendor will send their bid for consideration within a specified period. These bids are then sealed to increase confidentiality of each vendor's proposal. And then once the submission period is over, the recipient of the bid, Medicaid, which would be CMS, actually selects the lowest bidder. And that's who is awarded the contract. And some of the problems with this is that an equipment company might submit the lowest bid, but then when they're awarded the contract, may realize for whatever reason they can't deliver adequately and may actually close, leaving other companies to then match that lower bid. So it can be complicated. And the bottom line is that with the onset of competitive bidding, the reimbursement to these companies was cut by about half. So for example, if a company received $250 a month to supply a patient with their equipment, they may have been cut back to $125 a month, just to give you an example of the degree of the cut. The impact on liquid oxygen was really profound. The aspect of liquid oxygen came to light recently with COVID, and because many hospitals' internal oxygen supplies are based on liquid, it was specific plumbing, et cetera. So we read a lot about this shortage. The impact from competitive bidding is because the price to deliver liquid oxygen to the patient includes the cost of very specialized trucks and equipment and weekly deliveries, which is manpower and drivers, respiratory therapists, personnel. The patients have weekly deliveries to refill their reservoir tanks at home. So you can see in 2004, we had about 80,000 liquid oxygen users in the United States. 2016, that was down to 8,000. So you can see the profound drop in service to those patients. So one of the key aspects of reimbursement limitations is it really impacted the individualization of equipment. And we know that every patient is not the same. This gentleman reclining on the couch here is actually on the cover of the CMS booklet. It's a home oxygen booklet, and we all know that our goal is to get patients out of the home. So the reimbursement did not take into consideration individual patients' lifestyle, individual oxygen needs, high flow versus low flow. There are different types of disease states, have different projection or trajectories of disease progression. Some patients have a low flow need over long years of time, and others have very high flow needs that can progress rapidly within 6 months. So equipment is a big issue. There was a small bump to get a higher reimbursement rate for those on what we would call high flow, but that was at the loss or a cut in the reimbursement to patients on low flow. This is just courtesy of Chris Garvey, one of my colleagues and co-authors on some of our oxygen publications. This is Dante's Oxygen Competitive Bidding Hell. You can see the complex trajectory and path for a patient and for the professionals to get the oxygen to the patient. Just an illustration there. So what role do patients and advocacy organizations play? This is a picture of myself and Anna Eshu, who's a United States representative on Capitol Hill. I was there on a Lamb Hill Day where I accompanied other professionals and many patients, and up on Capitol Hill and individually meeting with various legislatures and educating them on the needs of our patients with oxygen. And I've shown this slide before at an American Thoracic Society symposium, and it really illustrates how unique oxygen is and how it crosses so many boundaries and so many patient populations and so many professional organizations. It is unlike no other treatment in that aspect. Inpatient, outpatient, critical care, palliative care. So multiple groups have partnered, and not the size of these circles is not important. The Pulmonary Fibrosis Foundation has been very consistently involved and advocating for their patients, both within ATS, within their own individual activities, and within the Public Advisory Roundtable. So we have COPD patients, American Association of Respiratory Care, Pulmonary Fibrosis Foundation, American Association of Home Care, American Lung Association, various industries, pediatrics, nursing, pulmonary rehab, academic community, Pulmonary Hypertension Association, the Lamb Foundation, Scleroderma, Tuberous Sclerosis Complex, primary ciliary dyskinesia, and lung transplant and alpha-1 patients. So a huge community that really has come together under various umbrellas to really advocate for these patients and oxygen needs. In 2017, in the Nursing Assembly, we had a planning group that really was sitting one day and discussing just our frustrations with hearing our patients bringing to us their issues and frustrations with getting oxygen services. So we published a survey on 1,926 patients. About 43% reported that their portable system limited their activity outside of the home frequently. 35% reported being very or somewhat unprepared to operate their equipment. We found that 70% of patients were being educated on their equipment by their delivery truck driver. We also found that having problems with oxygen was associated with an increased number of hospitalization days in the previous year. So it was important, and it was the first survey that really captured patient perceived problems. Patients reported that they currently had around 1 to 2 hours, most of them, of portable oxygen, but that they wanted 4 to 6 hours of portable oxygen. So a large discrepancy in their need for what they actually had. And 50% reported their equipment not working, travel problems, and you can see the numbers out of a total of 900. Delivery problems, lack of portables they could manage, lack of high flow, and on down the list. So many, many problems. After this survey was published, a workshop was convened, multidisciplinary, with many of the foundations of the previous slide that I showed you represented. And additionally, we had the FDA there, we had a CMS representative, APRIA representative, NIH. So very diverse experts. And from this all-day workshop, this panel confirmed that the findings of this workshop confirmed the existence of significant barriers to optimal supplemental oxygen therapy from all perspectives. Following the workshop, one of the recommendations was the lack of, to fill the lack of guidelines for clinician practice. So just recently, the oxygen clinical practice guidelines were published, and these recommended the use of oxygen in COPD and ILD patients who had resting hypoxemia to improve survival. The guideline panel and the review of the evidence and literature also suggested use of oxygen with exertion-only hypoxemic patients. The data here was just not as evident. It wasn't as abundant, I should say. There was just not enough data. But the data that was there did support the use of oxygen with exertion-only hypoxemia. The panel also recommended the use of liquid oxygen for patients who use more than 3 liters per minute continuous flow and who are mobile outside of the home. And lastly, they had a standard of care recommendation for training and education for all patients and their caregivers. So at this time, between the survey, the workshop, and then on later the guidelines, the Capitol Hill Foundation, CMS, were really hearing for the first time the presence of oxygen problems. Adding to this awareness, many advocacy groups drafted letters. And in 2018, there was a letter to Human Health Services after our survey, and had multiple sponsors sign on. Another letter went out in 2018 to Seema Verma, who's the administrator of CMS. This letter addressing the issues with competitive bidding. And later again in 2019, a letter went to Representative Gabbard in response to a patient who had had liquid oxygen removed from her. And then in 2020, another letter requesting a waiver, just during COVID, to in-person testing and delivery signatures, which was actually approved. And then one of the key occurrences in September 2020, CMS opened a call for comments. This is a period where the public is allowed to provide input, and this was for a national coverage determination on oxygen for the use of cluster headaches. But the advantage was that it also included an opportunity for comments for any other changes in oxygen policy. So this included, and these were, you can actually sign on to the website, and I've included the link here later in the slides. You can actually read the comments that came in from professionals, respiratory therapists, physicians, equipment companies, and patients. So it's very interesting to read. And this period for comment is open for a specified time. And then CMS takes into account those comments and makes a decision. So some of the comments requested that allow the prescription of oxygen for COVID patients. So both an acute, not just a chronic stable state condition. They asked to remove in-person testing. They asked for a standardization of a healthcare provider's dictation template and to actually remove the certificate for medical necessity form. The request to remove the word home in the title of the NCD. To change on the CMN form liters per minute to include pulse flow devices, which are a number setting. Include titration by oximetry and recommended retesting after discharge, and the use of respiratory therapists in the home setting. These are just a picture of what these letters look like. You can't read them, but I just wanted to show you examples. They come out with branding with all the logos of the supporting foundations. This was the letter that requested a waiver of testing. This was another letter requesting budget neutrality to suspend it, because every time they would approve an increase in funding for liquid patient, it meant that a person on lower flow had a decrease in funding for the DME provider. And this is another letter, again, asking for the removal of that budget neutrality. So the special interest group, the oxygen special interest group really started around 2018 when the first survey came out, and we've now been in full force for the past few years and meeting regularly and really trying to use the leverage of our multiple representatives from different advocacies, patients, professionals, therapists, nurses, physicians. And in around 2020, Gary Ewert, who heads the governmental relations, really made the statement that compared to 3 years ago, the Hill is now finally aware of the oxygen problem as a result of patient community efforts. Also in September 2020, Kate Gates of the Pulmonary Fibrosis Foundation presented a survey. This was during the shortage, where we worked together with them and looked at ILD patients. I'm sorry, this was before the COVID, but this was looking at competitive bidding and identifying patients that were still experiencing problems in service quality, costs, inadequate flow rates, unreliable equipment, and barriers to travel. And it really has stayed around 50% of patients, which is really an unacceptably high number. So where do we stand now? This is just a picture I took recently in our clinic of a gentleman who had an engineer friend rig a platform on his walker so that he could in fact travel around with his high flow oxygen and be able to walk independently, not have to drag e-tanks behind him while he used a walker. So again, really illustrates the need we have for device development for more portable high flow devices. So the other things that we've done during the COVID, which I mentioned earlier, there was a letter to the White House COVID response team that reported results from a survey that the PFF and ATS undertook to really quantify the shortages that were being seen across the United States, and just brought to their attention, again, the importance of planning for this, not only for the current COVID pandemic, but to address this in the future. And in the same letter, they also, again, went back to the continued pervasive problems within the oxygen market to, again, bring this to their attention. Now, this past March, the American College of Chest Physicians had a roundtable. It was a webinar, and the recurring themes, again, come up: access to high flow oxygen, device technology, COVID shortages. The other issue around competitive bidding and the inadequate reimbursement and how the impact of competitive bidding has been on the benefits to home oxygen. Provider documentation has been a huge issue that recurs. It's a large burden for staff, the nurses that are filling out these forms, the physicians that are again and again asked to redo their documentation. And then the role of advocacy and potential policy changes. How do we leverage all of our advocacy organizations, which really has really moved forward, which we can see. There was Hill Day this last March, and the Pulmonary Fibrosis Foundation had 60 advocates from 29 states met virtually with 60 members of Congress and over 100 meetings. They requested language and funding reports to the NHLBI, the National Heart and Lung Blood Institute, on the importance of pulmonary fibrosis research, and reminding them that they funded the initial bench research that went on to develop the clinical trials that the FDA approved our 2 drugs that we use for it today. So this was because of NHLBI funding. And they also want to make sure that they requested that they maintain pulmonary fibrosis as a topic in their peer-reviewed medical research program at the U.S. Department of Defense, which is another funding group. And they want to make sure that pulmonary fibrosis funding research is maintained and kept a priority. So it was very effective, even though they couldn't be there in person. So more recently, our ATS Oxygen Special Interest Group meetings have focused on some legislation that the American Thoracic Society, along with the Lung Association and the American Association of Respiratory Care, are drafting, along with input from many organizations. And this proposal is just being drafted. Nothing has been submitted yet. The goal is to include the removal of oxygen from competitive bidding, with at least removing, as a fallback, at least requesting the removal of liquid oxygen from competitive bidding to allow better reimbursement for that mode of oxygen delivery. To give CMS the authority to create modality-specific payments. In other words, payments could be adjusted based on if it's liquid or high flow, or another numbers of tanks for high flow. They would use, proposing to use payment plus the consumer price index rates as a new payment starting point. They're proposing to include what they're terming recapitalization payments, which would be reimbursement or upfront payment to oxygen companies to allow them to get back into the liquid oxygen market, because there would be an initial outlay of the special trucks and the equipment and personnel that would need to be given an upfront payment. Another proposal is to capture service-related costs and include service costs and oxygen payments. This is because currently the payment system only pays for equipment. So the durable medical equipment companies, reimbursement from CMS is for equipment, tanks, concentrators, home fill units, not for the personnel to deliver them, to educate patients, not for the personnel in the office, education. So it's just for the equipment. And the proposal is to change that, to add reimbursement for the service component of the DME business. And lastly, they propose that there will be a Bill of Rights for patients on supplemental oxygen, which is, of course, an outstanding proposal. So our other group, the Pulmonary Fibrosis Foundation, is continuing their advocacy with Hill Day, supporting other efforts. The Lamb Foundation, who are also, Sue Sherman sits on the American Thoracic Society Public Advisory Roundtable. The Lamb Foundation, a group of patients from a previous conference where the patients determined that the priority was to have device development to provide a high flow, portable, lightweight, FAA compliant device. We're successful in getting this is a small business innovation research grant funded by through the NIH. And this was successfully funded as a result of these patients' efforts. And it was just recently, the submission period ended and the funding was awarded to 2 recipients to develop this high flow, lightweight, long lasting device. And the winner at the end of a year with a device, or at least far along in development, one of these will be selected to go on to develop their device. And since this slide, there's been another group, again through the NIH, with another funding opportunity, and that funding period, the application just recently closed. So we have another award that will go out to device development. So this is a huge need, and it's very good to see the efforts of advocacy successfully funding. So we're waiting with bated breath to get those device winners. And the COPD Foundation, and another interesting advocacy effort, had feedback from patients who were buying POCs online that were not FDA approved. There was no oversight, and were found to be inappropriately represented as delivering certain amounts of oxygen, but when tested, they were not. And the devices were not appropriate for many patients, but there was no oversight. So they have drafted a letter to submit to industry in an appeal to get better oversight over these POCs and eliminate them from unregulated POCs being marketed online. So just recently, the National Coverage Determination for Oxygen did announce changes after receiving these comments from CHEST and multiple organizations. They did remove language that referred to that chronic stable state requirement, which is a great success. They've removed the requirement for the patients who have tried prior use of alternative treatments before oxygen in the home can be used. They are now allowing home oxygen coverage for patients who have acute needs, acute hypoxemia, and a shorter term. And this, of course, mainly came about because of COVID. They've expanded retesting to a longer period of time. They've removed the CMN and now rely on the local DMEs to manage orders based on medical record documentation. Unfortunately, they did not remove the word home from the title. So these changes haven't yet been implemented. This is very recent, and it's yet to be seen exactly how they will be implemented in the DMEs, but it is progress, and there's some positives here. So that's been reassuring. The other things we can do with our patients and ourselves in terms of improving care through advocacy and legislative changes is providing our patients with the Medicare rights booklet, which the Pulmonary Fibrosis Foundation has available, encouraging patients to call 1-800 Medicare to report problems and to participate in research to generate evidence for supplemental oxygen and development of new devices. I would add that the legislative effort that's underway right now has included a call to foundations to solicit not only data, but patient stories and letters. And that's actually underway right now through all of these foundations that I've spoken about, to gather these stories and document the problems. And those stories and data will all be submitted along with this legislative proposal that will be going to Congress. So it's just a perfect example of the strength of advocacy through our patients and ourselves as professionals. And it crosses, as I mentioned before, many groups. So we're having respiratory therapists, nurses, physical therapists, patients, industry, foundations. It's really multidisciplinary. So encourage your patients to become advocates. This is the Pulmonary Fibrosis Foundation has a website, how to become an advocate. They are completely supportive and will assist you in every step of the way. Our group at Stanford participate in the walk every year, whether it's virtual or in person, and have contributed to raising funds for the Pulmonary Fibrosis Foundation. And these types of advocacy activities are critical to raise awareness. You can see here on the right, the Pulmonary Fibrosis Foundation advocacies at work on the Hill. This is just, we don't need to travel, I think is something I forgot to mention. We all have town halls of our US representatives and our Congress congresswomen and congressmen in our own areas. So we don't need to travel to Capitol Hill, and patients can understand this as well. You can phone into a town hall, you can attend in person, but it can be local. And this is the off the website, become a PFF advocate. So you can learn more about that and the PFF's policy priorities by going to their website. So again, I thank you and I encourage all of you to become involved. There is great strength in so many of us that are very committed to helping our patients get out of the house and be mobile. So thank you all.
Hello, everyone. My name is Charles Boudreau, and I'm a clinical staff pharmacist at the University of Kentucky in Lexington, Kentucky. And today I'll be talking with you about idiopathic pulmonary fibrosis, or IPF, more specifically the pharmacotherapy considerations and then some future directions in terms of treatment. So to get started, I have nothing to disclose. We will briefly talk about some learning objectives that I hope that you can gain through this presentation. So first, I hope that through this presentation, you'll be able to describe just some relevant background information regarding idiopathic pulmonary fibrosis, or IPF, including the proposed etiology, the pathophysiology, as well as just a little bit about the history of treatment with IPF. Second, we'll together compare and contrast some currently available pharmacologic as well as non-pharmacologic agents and treatment modalities in IPF. Third, we can explore some appropriate methods to manage our antifibrotic or AF therapy in our IPF patients, including monitoring for adverse events, laboratory monitoring, and then some treatment outcomes. And then finally, we'll end the presentation with a brief discussion of some future directions in pharmacotherapy for IPF. So to get started with a little bit of background information on IPF, it's basically a spontaneously occurring and often progressive chronic fibrosing interstitial pneumonia. It is associated with a usual interstitial pneumonia, or UIP, pattern on high resolution CT or lung histology if a biopsy is pursued as part of diagnosis. In terms of prevalence and incidence, it is a fairly rare disease with a prevalence ranging from about 1 to 28 per 100,000 people based on geographic location, and an incidence anywhere from 0.2 to about 9 per 100,000 people. Unfortunately, IPF is a terminal diagnosis with death occurring within 5 years for the majority of patients. So something we definitely want to focus our treatment on and future treatments on. In terms of pathogenesis with IPF, it's not really clear at this point, but there is ongoing research. There are proposed risk factors and there are proposed mechanisms. So in terms of proposed risk factors, cigarette smoking is a large one. Age, especially patients in their 60s and 70s, they have a higher likelihood of developing IPF. Male gender, some genetics, and then viral infections, specifically herpes virus infections, some environmental pollutants, and then gastroesophageal reflux disease, or GERD. There are other risk factors, but these are some of the potential ones. In terms of the proposed mechanism, the working mechanism with current research is that some kind of non-specific injury to the lung by some kind of antigen initiates IPF in a susceptible individual. So by susceptible, I mean likely genetically. In terms of that genetic predisposition, it is thought to influence IPF, and there has been a familial association noted with patients with IPF. So we often ask that when we're working up patients in initial visits. In terms of potential gene involvement, there are many potential genes that could be involved in IPF pathogenesis, so surfactant proteins A2 and C, ABCA3, MUC5, telomerase, and then telomere length is another big area of research. So a lot of potential gene involvement in IPF, but research is still ongoing. So in terms of the historical context with IPF, I think it's important to discuss this a little bit because treatment has evolved over time. So back in the 1960s, when IPF was really being classified as a disease state, it was originally hypothesized to result from chronic inflammation. So basically alveolitis leading to chronic interstitial fibrosis. Based off of that hypothesis, interventions were mostly directed towards stopping the inflammatory response. So providing patients things like corticosteroids, immune suppressants, treatments like that. However, in the 1980s, some of the initial research was starting to show a more fibrotic pathway for IPF. So alveolar macrophage-derived growth factor actually was shown to lead to fibroblast proliferation. So fibroblast cells basically create fibrotic tissue in the lungs. In the 1990s, that inflammatory hypothesis that was originally used for treatment was actually disproven. And a lot of the research that was coming out, basically all of it, did not find any benefit for treatment with things like prednisone or corticosteroids or immune suppressants. So based off of that information, they needed to discover what really was causing IPF, as it didn't seem to be something that was from chronic inflammation. In the 2000s, early 2000s, they really discovered that fibroblast proliferation and fibrotic foci are really more implicated in IPF pathogenesis. And we'll see that this is really where our treatment lies in modern times. So let's talk a little bit more about contemporary treatment for IPF. There are two main agents that we use that are approved for IPF. They're called antifibrotic or AF medications. In 2011 through 2014, nintedanib was approved for the treatment of IPF. This is a inhibitor of multiple tyrosine kinases. In the earlier phase 2 trials, they showed about a 70% reduction in the rate of forced vital capacity or FVC decline in these patients with IPF. This is a marker of disease progression. And then an over 80% in reduction in acute exacerbations of their IPF. Later on in their phase 3 trials, they showed about 125 milliliter difference in that FVC decline. Important to note here, this is a difference in decline. So both patient groups did decline ultimately. Their lung function still got worse over time. The nintedanib slowed that down. So that is an important talking point that we have with our patients, that this is not a cure. This is a palliative treatment to help slow progression. Nintedanib was approved by the FDA in 2014. Pirfenidone is an inhibitor of fibroblast proliferation. In the early trials, they found that about 48% less patients experienced a greater than 10% FVC decline or mortality, which is a pretty large impact. They also showed an improvement in progression-free survival with IPF. Based off this data, pirfenidone was approved by the FDA in 2017. So these are our two main agents available to help treat IPF, and we'll spend a little bit more time talking about some specifics with them next. So to provide some overview on the treatments in general, as I mentioned, both nintedanib and pirfenidone are approved for IPF treatment in order to slow progression. They're not a cure, but they do help treat patients. Both agents are specialty medicines with unfortunately very high cost, somewhere between $90,000 and $100,000 per year. This is out of pocket cost if patients had no insurance. However, it is important to note that there is insurance coverage available and there are different foundations that can help pay for the medications for most patients. In terms of guideline recommendations, either agent is recommended if available for IPF to treat. The question arises then is, how do we choose between these agents that have similar efficacy, similar cost, and aren't really differentiated in recommendations? So that's really where the side effect profile comes into play with these two medications, and we're going to discuss that next. So looking a little bit more on nintedanib specifically, as I mentioned, this is a receptor blocker for multiple tyrosine kinases, which ultimately prevents the production of fibrogenic growth factors. So blocks some of those pathways that ultimately cause fibrosis in the lung. It is dosed at generally 150 milligrams or 1 capsule twice a day, but we can reduce the dose for various reasons to 100 milligrams twice a day. In terms of adverse events, really the GI or gastrointestinal adverse events are the main issue with nintedanib. So diarrhea was common. 2/3 of patients almost experienced it. Nausea, very common. Vomiting, fairly common. Liver function test or LFT elevation is also fairly common, and that plays into the monitoring for these medicines. In terms of warning, they do recommend cautious use in patients with cardiovascular disease or CVD, and we'll discuss that a little bit more in the coming slides. There aren't very many drug interactions to consider with nintedanib. Cytochrome P450, 3A4, or CYP3A4 inducers, so things like rifampin, for example, do interact with nintedanib. Not too many others, however, do. Blood thinners such as aspirin or warfarin also interact with nintedanib, and that is something we monitor for. And then finally, tobacco smoke is a very important interaction with both nintedanib and pirfenidone, which I'll talk a little bit more about. In terms of monitoring, we focus on LFTs. We get the liver function test prior to initiating, and then every month for 3 months, and then every 3 months thereafter. Switching gears to pirfenidone, as I mentioned, this is a medication that ultimately blocks fibroblast proliferation through multiple mechanisms. It's dosed at 801 milligrams 3 times a day. And in terms of side effects, more commonly, it's known to cause a rash or photosensitivity. This is something that is mainly related to sun exposure, so it's very important to tell our patients to wear a high, like SPF 30 or 40 sunscreen when they're going to be out in the sun if they take this medication. It can unfortunately also cause nausea and diarrhea at lower rates than nintedanib. It can also cause fatigue fairly commonly for patients. Not very many drug interactions to note for pirfenidone. However, just like nintedanib, it does interact with tobacco smoke. So what we tell or evaluate all patients for is current smoking, and we do not prescribe antifibrotic therapy if patients are current smokers. One, because smoking will likely increase the risk of disease progression, and two, since tobacco is an inducer of CYP1A2, which metabolizes both pirfenidone and nintedanib, it will greatly reduce the drug concentrations for both medications and likely render them either ineffective or not as effective. So for that reason, we do not prescribe these treatments for patients if they're current smokers. We instead focus on helping them quit smoking. Monitoring is similar with pirfenidone versus nintedanib. LFTs prior to initiation, then once monthly for 6 months, and then every 3 months thereafter. So just some considerations when you're deciding on appropriate treatment for your patient. As I mentioned, adverse events are common with both nintedanib and pirfenidone, unfortunately. In our clinical experience, we found that with nintedanib, the GI adverse events, so nausea, diarrhea mainly, occasionally vomiting, are much more common with nintedanib versus pirfenidone, though they can also occur with that medicine too. However, we've also noticed that fatigue seems to be a much more common side effect in our practice with pirfenidone versus nintedanib. This plays out in the clinical trials, but this is just something that we've also noticed in our practice, and we use it to help decide treatment. Pirfenidone, since it does come in those 2 tablet size and is titrated over a couple of weeks, does allow for some more precise dose adjustment for toxicity. So that is something we take into account for patients. Additionally, with nintedanib, I did mention that for anticoagulants or blood thinners with nintedanib, this is not a contraindication. This is just a precaution for patients. So using these medicines such as warfarin or aspirin with nintedanib can increase your risk of bleeding. However, this risk is not large. So this is something that I discuss with patients if they're on blood thinners, but it's not going to be a reason to not use nintedanib if it is the only, especially if it's the only medicine available. So the next question arises is, what about nintedanib and that cardiovascular risk that I mentioned on the previous slide? So when they were originally studying nintedanib in the phase 3 trials, they did note that comorbid cardiovascular disease is rather common in patients with IPF. A lot of patients had coronary artery disease, had a history of myocardial infarction, things like that. In the phase 3 trials, they did find different rates of certain cardiovascular events versus placebo with nintedanib. They found that specifically the rate of myocardial infarction, or MI, was 2.7% versus 1.2% in placebo, so over 2 times higher. But the rates of ischemic heart disease, so development of things like coronary artery disease, things like that, were actually significantly lower in the treatment group at 1.7% versus 3.1. So kind of these competing things, one was higher, one was lower. Ultimately, the FDA and the drug manufacturer recommends cautious use in patients at high cardiovascular risk. So let's delve a little bit more into that cardiovascular risk because there is further research. So in 2019, there was actually a post hoc analysis completed of nintedanib's cardiovascular safety. They included 720 patients taking nintedanib versus 508 taking placebo. And ultimately, they found that in high-risk patients taking nintedanib, there were some interesting results. High risk means patients with high blood pressure, hyperlipidemia, so high lipids, diabetes, obesity, things like that. They found that the risk of major adverse cardiovascular events, so stroke, MI, heart disease, anything like that, referenced as MACE, was very similar between groups. So no large difference, no significant difference between them. However, rates of myocardial infarction were, just like in the phase 3 trials, higher in the nintedanib group at about 3 times versus, or 3 per 100 patient years versus 1 per 100 patient years. Rates of ischemic heart disease, just like the phase 3 trials, were also lower in the nintedanib group. If you're looking at our low-risk patients who didn't have any of those risk factors, they had non-significant differences in their MACE and MI rates, and they also had a lower rate of ischemic heart disease with nintedanib. So in conclusion, and what I tell patients is that ultimately nintedanib seems to have a similar cardiovascular risk to placebo. However, if someone has risk factors for heart disease or they have heart disease, we do use this medicine with caution. I explained that there could be risks. They could have higher chances of developing heart disease or myocardial infarction. However, the benefits of treatment could outweigh that, or they could not outweigh that based off this discussion with the patient. So it's not going to stop us from prescribing the medicine, but that is a risk versus benefit discussion we have with the patient. So let's transition into managing the common side effects of our antifibrotics. As I mentioned with nintedanib and also somewhat with pirfenidone, diarrhea is a really common side effect that a lot of patients experience. In the trials and in our practice, they use loperamide, which is a common over-the-counter antidiarrheal medicine, to treat this, and it is very effective for most patients. So we do recommend this as our first-line option for people. Alternatively, we have prescribed bismuth subsalicylate, another over-the-counter anti-nausea medication. It also helps for diarrhea. So occasionally we use that too. So sometimes in our practice, we've had patients on both or just one, but generally we go with loperamide first for diarrhea. Fluid repletion is very important with diarrhea. And then also if things aren't improving, we can either reduce the dose of the medicine or we can interrupt treatment, which is fairly common. Nausea is unfortunately a very common side effect, as I mentioned. I generally recommend people take the medication immediately after a meal if possible, because if you have a nice full stomach when you take it, you're usually less likely to have side effects. Other options that we've used for patients, we sometimes prescribe the anti-nausea medicine ondansetron, as long as patients don't have any contraindication to using it. And we found that a lot of people benefit from that. So we have people that take 1 or 2 doses of their anti-nausea medicine per week, and it's allowed them to stay on the full dose of their antifibrotic medicine, which we think the benefits probably outweigh any risk of side effects at that point. Of course, we can also reduce the dose or interrupt treatment as well. For LFT elevation, it does depend a little bit on which medication is prescribed, and I go off the treatment protocols when they study these medicines. So we'll talk a little bit more about that. So for LFT elevations with nintedanib, if they're less than 3 times the upper limit of normal for their AST, ALT, or their ALK Phos, so those 3 liver enzymes we look at, we do not generally adjust treatment at all. We just routinely monitor them. If they're between that 3 to 5 times range, we can either reduce the dose or we can interrupt treatment depending on the patient and depending on their wishes too. If they're getting to that higher range, the 5 to 8 times, we would definitely interrupt treatment and we would consider restarting at a lower dose if the patient isn't already on it, as long as their LFTs resolve, which they usually do. Finally, if they have any signs of liver damage or if their enzymes are greater than 8 times the upper limit, we would permanently stop the medication at that point. I will say in practice, I have not had any patients where we've had to stop treatment with either nintedanib or pirfenidone due to LFT elevations, but they did note that in clinical trials, somewhere around a couple percentage of patients did stop for that reason. Pirfenidone's a little bit more straightforward. If they're less than 3 times, we don't do anything. If they're 3 to 5 times the upper limit of normal, they say use your judgment. You can continue it, you can interrupt it, you can stop it. We generally lean towards interrupting or taking a short break from the medicine if possible, just based off our practice, just to be safe. If they're at 5 times the upper limit of normal and their total bilirubin is greater than 2 times, or if they're anything above that at all, we would permanently discontinue the medicine based off the trial protocol. So generally, when I'm monitoring patients on antifibrotics, this is what I use to decide on our treatment pathway for LFT elevation. So moving forward to a very common issue experienced with antifibrotics and with IPF. So IPF progression despite treatment. Many patients, in fact, most patients with IPF will continue to progress despite treatment, maybe at a lower rate, but it will very likely happen because IPF is often progressive. Nintedanib, in terms of progression, defined it as an FVC decline of greater than 10%. Pirfenidone used a little bit of a different criteria. They did include that FVC decline, but they also included a greater than 50-meter decrease in a 6-minute walk test, which is commonly used in IPF patients to judge disease progression. And of course, they use death as disease progression, which isn't as useful for us in practice. Some other markers that we use to define disease progression are progression based off their high resolution CAT scan or reduction in their diffusing capacity for carbon monoxide, so DLCO. This is something that we can get if we get full PFTs or pulmonary function tests, and we can look at that to see if they progress based off those results. Unfortunately, it's often difficult to determine if progression was slow due to treatment or not. So say, for example, I start nintedanib in a patient, they take it for 6 months, we get a PFT and their FVC is down 15% from previous. We don't know if without treatment, their FVC would have declined 20% or 30% since IPF is progressive. So even though they did still decline significantly, it's hard to tell whether that was because treatment was not effective, or they did find some benefit and we just slowed disease progression. So the question often arises is, what's next if patients progress despite treatment? What can we do to help them out? So in 2021, very recently, there was a retrospective cohort study completed in about 260 patients. It actually looked at the effects of switching antifibrotic therapy due to multiple reasons, generally disease progression based off CAT scan, PFTs, et cetera, or side effects. They actually found that in the group that switched treatments, either from nintedanib to pirfenidone or vice versa, they found significantly longer survival times in that switch group. Important to note, it was only 37 patients, so this is not a large-scale trial, and it is retrospective, so in the past. They found, though, that the median survival was 67 months versus 41 months, and so in the switch group versus the not switch group, so over a 2-year difference. We already switch patients if we find that their disease progresses, if they're open to it. However, this gives us a little bit more data that can be helpful in deciding what to do. So we generally try to switch patients if they have progression or if they have unmanageable side effects with one of the therapies, and we have found it to be beneficial too. We'll talk a little bit about some non-pharmacologic management of IPF. So of course, supplemental oxygen is necessary when needed for the patient when indicated. We do want to provide great education on the disease state and prognosis. Really important to explain to patients that this is unfortunately a terminal diagnosis. This is something that we cannot cure at this time, but we do have treatment available. Pulmonary rehab, or PR, is very important to us as a clinic. For COPD, there has been a large amount of benefit shown, including survival benefit in research. However, there isn't really any available research for IPF and pulmonary rehab that I'm aware of. They did complete a Cochrane review of pulmonary rehab and interstitial lung disease, which has similarities with IPF, and it didn't show improvement in quality of life. So based off this, we don't have hard data showing it's effective, but anecdotally, we find that referring people to complete pulmonary rehab makes a much larger difference in their symptomology than does prescribing antifibrotics. Of course, we're going to do both because we want to slow down progression, but people aren't going to feel any better when they're taking nintedanib or pirfenidone. They're going to feel the same, and that's what's supposed to happen. With rehabilitation, we find that patients are deconditioned before this, and going through rehab can really help them feel a lot better and improve their quality of life. So we recommend it for all patients. Of course, standard vaccinations are recommended for patients with lung disease, influenza, and pneumonia. We also try to refer people to either palliative or hospice care, as IPF is a terminal diagnosis. So if someone comes in with IPF, we're going to at least discuss palliative care with them. And that's only because we don't have a cure for this disease. And the earlier you establish, the better planning you'll have for your end-of-life care, even if it is something where you still have years to live. We also consider referral for lung transplant for all our patients, depending on specific criteria. That could be a whole presentation in itself, but that is something we also consider for our patients. So I'll go ahead and end the presentation with some future directions in IPF. As I mentioned before, there are no curative treatments for IPF, and survival unfortunately remains rather poor even after diagnosis and treatment. Our available treatments also have significant toxicity, which needs to be considered. Therefore, future treatments for IPF are vitally important at this time. These are a couple treatment strategies and targets that have been studied that are in the process of going through clinical trials. So Pentraxin 2 is a monocyte differentiation inhibitor, basically blocks another part of that fibrotic pathway in the lung, helps block it at a different spot to hopefully help treat or prevent fibrosis. GLPG 1690 is an autotaxin inhibitor. I didn't discuss too much about autotaxin, but it's also another progenitor of fibrosis. There is research into the combination of nintedanib and pirfenidone at the same time. In fact, the InJourney trial did show safety with this combination. However, the efficacy trial is still in progress. It's called the Progression trial. I know some practices already do this, some IPF centers. We do not at this time, just because we find there's a lot of issues with insurance approval for both medications simultaneously. But I know that some centers are already doing that, and that could be something we do in the future. Pamrevlumab is a monoclonal antibody that targets connective tissue growth factor, so it's another target for fibrosis. Imatinib is similar to nintedanib. It's another tyrosine kinase inhibitor. Thalidomide is an older medication that also has shown some antifibrotic properties, which has been studied off and on for the last 10 or 20 years. Finally, inhaled treprostinil is a prostacyclin analog that has shown benefit in patients with pulmonary hypertension and ILD. It's actually FDA approved for that. However, they're studying it for patients with just IPF and no other pulmonary complaints. So this will be another important medicine to consider in the future. So in conclusion, IPF, as I mentioned, is a chronic fibrosing lung disease. It has a poor prognosis and it has no curative treatment at this time. It's thought to arise from some kind of nonspecific injury to the lung by an antigen that initiates IPF in a susceptible individual. Our current treatment is unfortunately palliative. We focus on reducing progression of fibrosis. We're not going to cure it at this time, but hopefully we can slow it down and give people more life expectancy. Antifibrotic agents carry significant side effects that need to be considered, and we need to account for those. Our non-pharmacologic management likely improves, especially pulmonary rehab, likely improves quality of life in our IPF patients, and we consider that in all of our patients. And finally, on the horizon, there are many potential agents that are being evaluated for IPF that need to be considered and kept track of. So that's my presentation. Here are my references cited, and I will go ahead and take questions now. Thank you very much.
Hello, I'm Rebecca Edwards. I am a nurse practitioner from St. Joseph's in Phoenix, Arizona. I'm going to be talking today about transition to transplant, and our focus will really be on partnering with our patients and partnering with our local transplant team for the purpose of improving our patients' experience and improving patients getting to transplant. I mostly practice in the ILD space. However, I work really closely with our busy lung transplant program. So counseling patients about transplant early and getting patients to really understand this journey is something that I'm really passionate about. So I'm happy to be here and talk about this today. These are my disclosures. And then just to orient us to the topic, as a reminder, patients who should be considered for lung transplant are those who are at risk or at 50% or greater risk over the next 2 years of passing from their lung disease. And as people who take care of patients with all forms of fibrotic lung disease and really quite progressive lung diseases, these are patients who we're encountering in our clinics every day of our lives. And this diagram will be familiar to all of you. This is the clinical progression, the natural history of idiopathic pulmonary fibrosis. And again, really the takeaway I think from this is that the patients we care for, their disease progression will be unpredictable. And unfortunately, to date, we really don't have a good way of categorizing which patient will fall into which of these progression lines and which patients can experience acute worsenings. I think it's also important to remember, we take care of IPF patients. I think we're pretty well versed in how those patients are unpredictable and how they will behave. But just a reminder that many of the other ILD disease states that we're caring for can have similar prognosis to IPF. So for example, this is a slide reminding us that patients with autoimmune ILD can often behave quite similarly to those with IPF. So what our takeaway is that we're going to see this a lot. So transplant for ILD really is nothing new. In fact, transplant for ILD has now exceeded COPD as the #1 indication for lung transplant. And actually about a little bit over 40% of lung transplants done worldwide in 2017 were for some form of interstitial lung disease. And the numbers here in the United States were actually larger than that. Restrictive lung disease of various types accounted for 60% of lung transplants in the US in the year 2018. Interestingly, in spite of these numbers, data that's published still suggests that we're not capturing all patients who qualify for lung transplant, and that not all of those patients are actually being referred for consideration. These are a few publications of some different studies, some different patient registries that publish their data on transplant. IPF PRO is a registry looking at patients with idiopathic pulmonary fibrosis. And interestingly, of eligible patients, only 23.3% of those patients had been referred to be considered for a lung transplant. The University of Chicago published some experience with looking at transplant referral rates as well. And their numbers were a bit higher. They found that about 63% of patients with pulmonary fibrosis who were eligible had actually been referred. Interestingly, there seemed to be a little bit of a delay, so 7 to 17 months from actual eligibility for transplant to an actual referral being placed was present. And then patients who were not referred, it wasn't clear why they were not referred. This cohort was actually compared to a cystic fibrosis cohort of patients. And one of the interesting findings was that patients who have pulmonary fibrosis were more likely to have significant comorbidities, which certainly could have played into some of those findings of delay. And I think that doesn't surprise any of us who care for this patient cohort of ILD patients. Often our patients will be older and have more comorbidities. So this is something we'll dig a little bit more into later in our presentation. And then the Pulmonary Fibrosis Foundation Registry also published some of their data from data from care center sites. And they found that 595 patients with idiopathic pulmonary fibrosis who met transplant criteria were identified in their registry. 36% of those patients were listed for transplant, while 595 were not listed for transplant. So, of course, the limitation here is that we're just talking about patients who've actually been listed. We're not talking about referrals. Nevertheless, it's only 36 out of 595. And so of that 595 patient population, 410 of the patients actually had GAP stage 3 disease. And to remind you, patients who have GAP stage 3 are estimated to have a 62% mortality at the 2-year mark. So certainly seem to fit that criteria for 2-year 50% mortality estimate. So as I was preparing for this specific presentation and thinking about our Nurse and Allied Health Network, a couple of the questions that I was thinking about is how we can best serve our patients. So a couple of the big questions I came up with is, when do patients want to hear about transplant, and from whom do patients want to hear about transplant? So as I did a bit of a literature search, I will admit there was not a whole lot of information I could find specific to pulmonary fibrosis. However, I think as a group, we've learned a lot from the cystic fibrosis community, both in terms of how they've set up patient care networks, how they've set up patient registries, and just the amount of data that they've put out there. So I did find some cystic fibrosis information that I will share with you. Admittedly, the populations are a bit different, but I think you'll find that there's some data that we can take away from it. So as far as the when of transplant, there was a survey done of patients asking for what could be improved in terms of bringing up transplant, in terms of their whole experience, having someone speak to them about transplant. And patients identified a number of areas for improvement, but a few of those were timing of the transplant discussion, accuracy of transplant knowledge by their care team, and then also the stigma they felt was associated with having to talk about transplant or get a lung transplant. And what it really came down to is that patients identified that they would really like for transplant to be brought up sooner and almost have that as a more normalized conversation. Perhaps that would help with some of this stigma feeling with lung transplant. And then very interestingly, as far as whom patients wanted to hear about transplant, there was a very interesting study that our own Erin Mahoney was actually part of, looking at 8 different cystic fibrosis centers and asking patients who they wanted to hear about transplant from. And I think, not surprisingly, all of the patients wanted to hear about transplant from their pulmonologist. But interestingly, 52% of patients reported that they did start talking about it with other team members, and 88% of patients wanted to hear about transplant from a non-pulmonologist team member. In fact, 35% of those patients stated they'd actually feel more comfortable hearing about a transplant discussion from a non-physician team member. So they actually broke down which team members patients wanted to hear from. And following the pulmonologist, the number one non-MD team member was they wanted to hear about it from their nurse navigator. And then following nurses, they wanted to hear about it from their advanced practice providers, so their NPs, their PAs. So as a group of allied health, of nurses, I think this is something that we need to think about, is that patients do find it important to hear about these topics from us, and that what we're telling patients when we're bringing it up, the accuracy of the information we're giving, is really important as patients are making these really personal decisions. So leading it from that, I want to go through the lung transplant criteria, because we as the ILD team, we're going to be the first line in identifying patients who need to be referred. And so it's important that we know what we're looking for. And then I do want to highlight a little bit some of the criteria items that are modifiable, because we're the #1 team who's going to be able to help patients identify that and make changes. So first, this is the criteria for referral to a transplant center. And this is actually different than the criteria for listing to receive a lung transplant. And so the criteria is any patient who has UIP or a fibrotic NSIP on pathology or on CT imaging, and this is regardless of lung function. Already the patient is qualified if these factors are present. Any abnormal lung function with an FVC less than 80 or DLCO less than 40, any shortness of breath or functional limitation attributable to lung disease, any oxygen requirement, even if only during exertion. And then for patients who have inflammatory ILD, failure to improve after appropriate treatment. So I think we all wish that we would get these patients in our ILD clinics this early. But really what we need to be considering is that perhaps more of the patients that we see in clinic are qualifying or are appropriate to be consulted at a lung transplant center than we may think in our day-to-day busyness. This is for timing of listing, and I think this is more traditionally what we think of as an important clinical sign or worsening. So think about decline in FVC of 10% or greater, decline in DLCO of 15% or later or greater, and then desaturation on 6-minute walk test, development of pulmonary hypertension or respiratory related hospitalizations. And keep in mind, this is actually when patients should be considering listing for transplant, meaning they should have had all the workup done by now. There's a few special considerations I just want to mention. So, patients who have connective tissue disease, there can be a wide spectrum of how these patients will present in terms of lung involvement and also systemic involvement. So typically the rule of thumb is that patients should have failed standard of care therapy. But I will say in certain patient scenarios, particularly those who have significant esophageal disease and esophageal dysmotility, those are patients that should consider being referred a bit earlier, as addressing that esophageal component can take time, and patients often have to weigh out, risk benefits of some of the things they may be asked to do in terms of feeding tubes and that type of thing. So those are patients just to keep in special mind. So general candidacy issues. So we'll go through these quickly. These are absolute contraindications, meaning absolutely not. So recent history of malignancy, untreatable significant dysfunction of another major organ system, uncorrected atherosclerotic disease, coronary artery disease, medical instability. And then typically it's a BMI of less than 35 that's now considered an absolute contraindication. And then severely limited functional status with poor rehab potential. And then relative contraindications, and you'll find that these will vary center to center, patient to patient, looking at the whole picture. So think age, more than 65, a BMI of 30 to 34, progressive or severe malnutrition, severe and symptomatic osteoporosis, and then other medical conditions that have not resulted in end-stage organ damage. So what I do want to mention is that many of these contraindications are absolutely modifiable if we're starting early. I've bolded some of the ones that are definitely modifiable. The recent history of malignancy, we don't have control over that, obviously. However, we can encourage our patients to make sure they're keeping up with their cancer screens and talk to them about their risk based on other medications they may be using. For example, I think we all often treat our patients with azathioprine with mycophenolate. And I think it's really important that we're making sure that script goes right along with the referral to dermatology. So we're doing skin cancer screenings, doing everything we can to prevent or at least promote early diagnosis of malignancy, giving our patients a better chance. Uncorrected atherosclerotic disease, patients may need stents. I think there's a lot of documentation around the incidence of coronary artery disease in some of these ILDs. And patients who need stents may need to be anticoagulated for a period of time. So addressing these things, treating them earlier in their disease or while they still have some time rather than when they don't have 6 months to be anticoagulated can make a big difference in terms of transplant candidacy. Class 1 or 2 obesity, this is something we can address early on, get patients connected with nutrition, connected with medically supervised weight loss. Weight loss is tough. This can take time. Again, this is something it's great to address early on. And then functional status, I think most of us, I think especially nursing, we think a lot about pulmonary rehab. And so I would encourage that to be brought up and addressed every visit, and ask patients, if they're not going to rehab, what are you doing for exercise at home? And make sure that they're at least incorporating simple things. Relative contraindications, most of these are actually modifiable. So again, we talked about obesity, malnutrition, we can counsel about, we can get dietetics on board early. Severe and symptomatic osteoporosis, often we use high doses of steroids and patients can be on prolonged tapers. So bringing up bone health, making sure patients have had DEXA scans, that their vitamin D, their calcium is being optimized. That can do a lot for prevention. And then medical conditions that have not resulted in end-stage organ damage. So encouraging patients to keep up with their primary cares. Often when you're chronically ill, your specialty team becomes your main people, but just reminding them that their health maintenance is important, especially as we look down the road and think about what they may need in the future. And then things like GERD, I think most of us are screening for that. These really should be optimally treated prior to transplant. And, general wellness, I will also mention that dental care and dentition is one of the things that can often delay transplants, with patients needing to have teeth pulled. So even care like that, patients need to keep up with. So in patients going for lung transplant evaluation, what can I expect now? So similarly to an ILD team, a transplant team is a multidisciplinary team as well, and it's comprised of pulmonologists, transplant surgeons, pharmacists, infectious disease specialists, social workers, psychiatrists, psychologists, nurse navigators, advanced practice providers. Typically, when a patient goes for a transplant evaluation, really their first line person is going to be the pre-transplant nurse navigator who walks the patient through their entire workup. And then post-transplant, again, a nurse navigator will be the person who really is the frontline face of care for that patient and make sure that all of their care is being coordinated appropriately. I usually tell my patients when they go for a transplant workup that they're about to get the best physical of their life. And this is a general idea of what a transplant workup will involve, which is chest imaging, PFTs, cardiac cath, pretty in-depth esophageal testing, cancer screenings, and a number of evaluations with various team members. Patients have to have completed a pulmonary rehab program. So following the workup, patients are then presented to a multidisciplinary board, and every aspect of that patient is reviewed by the team. And then typically there's a number of outcomes. One is the patient is accepted for lung transplant and will move forward to listing at that point. Two, the patient is declined as a transplant candidate. There may be an absolute contraindication to proceeding with that patient. They're not likely to do well. And then three, it may be a not now. And that may mean that additional workup is needed. Perhaps an intervention needs to be made, such as a stent or other intervention, or it may be that the patient is too early. And often I'll find too early when we refer IPF patients. So often we'll refer our patients, they'll finish their whole workup, they're found too early, and they continue to follow with us in our ILD clinic with occasional check-ins in the transplant department. But then you have that safety net of a completed transplant evaluation in case the patient should have an exacerbation or an acute decline. These are the factors involved in the lung allocation score. Typically, this is plugged into a computer, their score pops up. You sure can calculate it by hand if you want to. It's quite cumbersome. And then these are the regions in which organs are retrieved for patients. So you can see that there's states that share these regions. And then as far as outcomes, typically a rule of thumb is that lung transplant survival is 50% at the 5-year mark. This can vary a little center to center, and then things like wait times vary quite a lot center to center. So a great place to look is the Scientific Registry of Transplant Recipients. This is accessible for anyone, healthcare members, patients. So you can look on and see what your local transplant team is reporting as far as their outcomes, and that'll also allow you to give your patients more realistic idea about wait times, things like that. And then, I think it's important that the ILD team and the transplant team were all important parts of the patient's care. Typically, while patients are going through a pre-transplant workup, their ILD team is still actively involved, making sure the patient has enough oxygen, making sure their medications are properly monitored, and taking care of the patient's underlying disease. A great way to interface with your transplant team is typically your patient will be assigned a nurse navigator, and you can call up your transplant program and information share easily that way. And I think our willingness to kind of reach out and have those bridges really makes a huge difference for our patients' experience and as they navigate what can often be a big transition for them. So a few summary points. So many of our patients, they will qualify for lung transplant consideration. So it's our job to be on the lookout for that and make sure that patients are able to do what's best for them. This is a deeply personal decision. And I think as nurses, as allied health professionals, we're really poised to be there for patients and help them navigate these decisions. And patients want the lung transplant conversation to be normalized and discussed early by multiple team members. I think by it being a normal part of a visit, it doesn't feel quite so full of stigma or so scary. And then remember, nursing and allied health is the people that patients are asking to talk about this with. Guidelines suggest that we should refer some of our patients early in their disease course. I think we've talked about that. And then many contraindications to lung transplant are modifiable. And again, as nurses, as NPs, as other allied health, I think we're in a great position to be able to identify some of those and help patients navigate the health system to make sure that they're getting all the proper care. And then outcomes for your local lung transplant program are posted. These are my references. Thank you very much.
Hi, my name is Annalise Calypso, and this talk is in regards to autoimmune interstitial lung disease and pulmonary hypertension. Again, Annalise Calypso, I am a nurse practitioner in the interstitial lung disease program at Johns Hopkins Medical Center. What is autoimmune interstitial lung disease? Overview. What is autoimmune interstitial lung disease? I plan on discussing what is autoimmune ILD, the types, management, and treatment. Also, we'll be going over pulmonary hypertension, its groups, management, and treatment. I have no disclosures. ILD, so what do we know about it? We know that there are over 200 causes of interstitial lung disease, and the diagnosis can be challenging. Unfortunately, especially in my clinic, when patients present to our clinic, they've already been told that they have pulmonary fibrosis and that they have about 2 to 5 years of life left, which can be challenging and can hinder your diagnosis. So it's really important that you focus on what you do know and really get a good history and assessment from the patient while they're in clinic. So the types of interstitial lung disease, as you know, we have treatment-related ILD, we have idiopathic interstitial lung pneumonias, we have pneumococci such as asbestosis, silicosis, coal workers, pneumococcus. We have connective tissue disease, also known as autoimmune lung disease, which we'll be discussing today, and immunologic, which is sarcoid and hypersensitivity pneumonitis. So what composes autoimmune ILD or connective tissue lung disease, interstitial lung disease? Rheumatoid arthritis, systemic lupus erythemosis, mixed connective tissue disease, undifferentiated connective tissue disease, scleroderma, Sjogren's, and dermato and polymyositis. So as stated before, it is very important that during your assessment that you obtain a complete and thorough history. Even if the patient has stated it numerous times to numerous providers, there may be something that could be missed. So get to know your patient, take a good look at them, question their significant other or their spouse or who may be accompanying them during their visit, and really get a good extrapulmonary examination. So an extrapulmonary examination are things outside of their CT scan. So when you look at the patient, do you notice alopecia, growthins, papules, rash, whether on anywhere on their body, muscle weakness, proximal weakness? So are they able to raise their hands above their head? Are they able to get out of a chair? Do they note weakness? Ulcers, do they have them on their fingers? Do they have them in their mouth? Do they report difficulty swallowing? Choking with food, are there certain foods that they're forced to avoid? Do they complain of joint pain, Raynaud's, or in general, do they just complain of cold feet or that they can't tolerate AC? Sclerodactyly, do you notice any tightening of their fingers on their face? Joint inflammation that can wax and wane. Do they notice that at the end of a day that their hands get swollen or that their knees get swollen? Mechanics hands, calcium deposits, or pleurisy. Another component of our assessment is laboratory testing. So based on the extrapulmonary signs and symptoms that you can see on your patient can actually guide you as to what tests that you should obtain in your patients during their visit. So do you notice any skin thickening or, as stated before, esophageal symptoms or Raynaud's? You would get the SCL-70. Try and determine if there is a scleroderma component that could be causing their lung disease. Mechanics hands, as stated before, proximal weakness, rash or Raynaud's, you would obtain a CK aldolase, a myositis panel, anti-Jo1 if you want the results quicker, to determine if there's a dermatomyositis or a polymyositis. To touch base on the proximal weakness, what I mean by that is, again, are they able to raise their hands above their head? Are they able to get out of a chair without using their hands? So if you notice proximal weakness and they don't have a rash, then you can think of polymyositis. But if there is a rash, that would lead you towards dermatomyositis. Do they have dry mouth or dry eyes? Make you think of Sjogren's. So you get an SSA or SSB. Arthritis, do they have a rash or morning stiffness that goes away with movement? You'd get a SED rate, an ANA, a rheumatoid factor, anti-CCP. Just to touch base on rheumatoid arthritis, patients, they can come in and state that they have joint pain and stiffness, but you also have to differentiate whether or not it truly is rheumatoid arthritis. So that's where rheumatology comes into play. But if the pain is all day and regardless of activity, then that would lead you towards osteoarthritis. Rheumatoid arthritis, again, is patients report stiffness in the morning. It's alleviated with heat and movement. So that would lead you more towards rheumatoid arthritis. Also, do patients know a butterfly rash or rash with sun exposure, recurrent fetal loss, fever, malaise, or arthritis? It would lead you towards obtaining an ANA, anti-DNA, IgG, Russell venom viper testing, and that would lead you towards lupus. Unfortunately, I had a patient who came into our clinic a couple months ago, and she had seen, by then, had already seen 2 specialists, and she was getting worked up for her recurrent fetal loss. And after in-depth conversation, I asked her, how many miscarriages had you had? And she stated 5. Stated that she was, fatigued, that she had joint pain. And what brought her into our clinic was that upon deep inspiration, that she would have a pain on the left side of her chest. It was pretty much classified as pleurisy, no respiratory illness or anything like that of the sort around the time in which this started. And she never had been worked up for lupus. And unfortunately, we do see this in patients with lupus, that they do have recurrent fetal loss. Systemic sclerosis or scleroderma. Generally, we see in patients sclerodactyly, thickening of their skin, especially their hands or their face, They can have red spots on their hands and calcium deposits. Obviously, they can present with interstitial lung disease and later on pulmonary hypertension. Raynaud's phenomenon is also found in these patients. They can report joint pain or contractures. And a significant component of this disease manifests GI-wise. Heartburn, diarrhea, they can have constipation, esophageal dysmotility and swallowing difficulties, dry mouth, and gum disease. In regards to dermatomyositis, we can see a numerous amount of skin manifestations. And so oftentimes they're missed in our African American population, but we have patients who can present with photosensitive erythema that can later on develop into hyper or hypopigmentation. It looks like the shawl sign or a V-like rash on their chest or their back. Patients can also have a facial rash that is around their orbital region. In African American women, it can actually look like they have on eyeshadow. It looks like a discoloration of their eyelids. Also, these patients can have alopecia and erythema of their scalp. They can have periunguinal telangiecta, in which they have erythema and ragged cuticle. Grotrin's papules, hyperpigmented or red papules and plaques on their knuckles. Again, the shawl and the V sign here, you can see on a patient's back, but on African American patients, it can actually present as back knee or acne on their chest. It doesn't necessarily present as this confluent rash that you would think to see on patients. And you can also see this on their knees, ankles, this hyper and hypopigmentation. Another aspect of testing is PFTs. Also 6-minute walk testing and oxygen titration testing. Generally, we see that patients require oxygen once their DLCO is less than 50%, but it can take time for their disease to manifest in a pulmonary-like nature. For the most part, these patients, they report extrapulmonary symptoms, and then, you know, it's incidental finding on their once they get scanned that there's some form of interstitial lung disease or the manifestation of dyspnea. So when these patients do obtain CT scans, there are some classic signs in which that we see in this patient population. So the straight edge sign, which you can see here on the right, predominant honeycombing, it's also predominantly seen in the lower lobes. This patient right here is a systemic sclerosis patient who presented, and then this finding was found on her CT scan. And then we have the exuberant sign, which is predominantly found in the bilateral lower lobes, over here on the upper right-hand corner. This patient here is a 61-year-old woman with rheumatoid arthritis. And as you can see, it's predominant honeycombing. And yeah. And then this one, the anterior sign, again, another woman with rheumatoid arthritis. So don't rule out, regardless of what their disease is, no one really falls into a classic picture, and same patient, same age can present differently on CT scan. But this patient, as you can see, the anterior sign is in which you have honeycombing and fibrosis and some sparing actually, but predominantly in the upper lobes, but it can be found in the lower lobes. And again, this patient also has rheumatoid arthritis. So in regards to our patients with autoimmune interstitial lung disease, we really want to take a collaborative approach. you really need to develop a good relationship with rheumatology, GI, cardiology if necessary, and really have a plug-in with pulmonary rehab, exercise, maximizing their endurance, managing their weight, even including nutrition would actually benefit these patients greatly. So in regards to treatment and management, so for these patients with autoimmune interstitial lung disease, we often prescribe immunosuppression. Immunosuppression that we use are mycophenolate, azathioprine, Cytoxan, which we don't often use in our clinic, but patients have come presented to our clinic on this medication, Rituxan and steroids. We also often use IVIG, which can be administered at home or an infusion center. And then again, to increase their endurance and exercise capability and help maintain a healthy weight, pulmonary rehab. So the prognosis of autoimmune interstitial lung disease. The prognosis varies by disease. With early diagnosis and appropriate treatments, as stated before, immunosuppressant medications, IVIG, patients can do quite well and be stable for many years, if not decades, but it often takes time for us to find the right combination for the patient that works. But when it does, it is a vast, difference as to how they presented. Immunosuppressants, unfortunately, immunosuppressants can reverse inflammation and improve lung function to some degree, but we cannot fix the scarring that has already formed. So on to our next topic in this presentation, pulmonary hypertension. So as you can see, this is a lung, this is a normal blood vessel, and pulmonary hypertension is in which you have elevated pressures of the arteries. So again, what is pulmonary hypertension? It's essentially elevated pressures in the lung. Normal pulmonary artery pressure is between 8 to 20 millimeters of mercury at rest, and greater than 25 at rest, and greater than 30 millimeters of mercury with activity. So the symptoms of pulmonary hypertension, early symptoms are shortness of breath with routine activity, fatigue, infrequent chest pain, a racing heart rate. Oftentimes patients can report pain in the upper right side of their abdomen, a decreased appetite and or weight loss. And then later symptoms, feeling lightheaded, especially with physical activity, fainting, syncope episodes, swelling of the ankles or legs, bluish lips or skin. So to diagnose pulmonary hypertension, non-invasive measures include the echocardiogram, chest x-ray, CT, CTA, ventilation perfusion scan, also known as a VQ scan, and cardiac MRI. The gold standard is a right heart catheterization, and oftentimes, we don't wish to do invasive procedures on patients. So between your echocardiogram, which can determine your ejection fraction and whether or not you have an elevated pressure in your right ventricle, CT scan and X-ray can also determine whether or not you have an enlarged pulmonary artery. A VQ scan can determine as to whether or not there are clots present, and a cardiac MRI. So autoimmune ILD is commonly associated with pulmonary hypertension. We often find this as a sometimes late aspect of their connective tissue disease, and we primarily find this in patients with limited scleroderma. About 40% of our patients can present with pulmonary hypertension. And also we find this in patients who have a mixed connective tissue disease, who have an overlap of scleroderma and or lupus. So Crest syndrome, what we find in these patients with these manifestations predominantly end up with pulmonary hypertension. They can have calcinosis, abnormal deposits of the skin, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias, red spots on the skin. So if you see a patient present it doesn't necessarily have to be all 5, but if you see a patient present with this, just make sure you do a thorough cardiac exam. You know, if you hear a P2 early on in the exam or a right-sided shift or anything like that, definitely have them worked up. So pulmonary hypertension is classified into 5 groups. Generally speaking, based on the definition of these groups and our patient population, Group 1, Group 3, and Group 5 are where we would have our patients fall with a diagnosis of pulmonary hypertension. In Group 1 is idiopathic pulmonary arterial hypertension, in which it can be drug-induced connective tissue disease. And then Group 3, we have our interstitial lung disease patients with COPD and sleep apnea. And then the miscellaneous group are patients with sarcoid. So based on those definitions, we could have our patients fall into 3 groups. But I have seen patients who fall into all 5 groups, meaning you can have a patient with left heart disease, but have interstitial lung disease or have pulmonary fibrosis. We've had patients with CTEPH, you know, where you have blood clots in your arteries, but also have an overlap of lupus and scleroderma. So it doesn't, granted, yes, these groups help, but I've seen all of our patients be outliers in regards to these classifications, but they are a great guide as to what type of pulmonary hypertension our patients have. And then after thorough testing, we can determine as to what treatment regimen would be good for them. So what happens in these groups? So in Group 1, in pulmonary arterial hypertension, small pulmonary arteries thicken and stiffen, leading to increased blood pressure. So you have reduced blood flow. And then in Group 2, we have pulmonary hypertension due to left heart disease. The left heart doesn't pump efficiently, leading to increased pressure of the right ventricle. Then in Group 3, we have pulmonary hypertension due to hypoxia or chronic lung disease. So these, and a majority of our patients fall in this category. Low oxygenation causes these arteries to constrict, reducing blood flow. So you can have patients who are maximized on their immunosuppression, who are feeling well, but despite that, they note increased shortness of breath with minimal activity, or they can have a drastic change in their oxygen requirement. Chronic thrombolic pulmonary hypertension, also known as CTEPH. These are pulmonary blood clots that block the flow of blood, which also cause an increase in blood pressure. And then, as stated before, Group 5, which is other pulmonary hypertension, in which any of these manifestations can present. So treatment options are vasodilator therapies. And then we have vasodilator antiplatelet therapies, anticoagulant therapies, inhalation therapies, remodeling therapies such as nitric oxide, and then anti-inflammatory therapies. So the resources that I use today, I gathered from Pulmonary Fibrosis Foundation, Myositis Association, Scleroderma Foundation, and Pulmonary Hypertension Association. All of these associations will provide great information to help guide you in how to educate your patients in regards to their disease process. Any questions? Thank you.
Hi, I'm Chris Garvey. It's a pleasure to talk to you today about pulmonary rehabilitation and specifically the evidence base for patients with interstitial lung disease and IPF. These are my disclosures. So I will talk about the evidence base, what we know. The evidence base has grown over time, and there are still some gaps that we should be aware of, and we may want to consider strategies for how we approach these. And then I'll offer some resources. So I would say that things really changed in terms of referring ILD IPF patients to pulmonary rehab when the American Thoracic Society, along with collaborative societies, published the IPF statement in 2011. They advised that the majority of patients with IPF should be treated with pulmonary rehab, and clearly that it needs to be tailored to this patient population. Thank you. This is a study that Chris Ryerson and a group of us from California and a group from Canada published, looking at a prospective approach to assessing patients with ILD and a subset with IPF and providing standardized pulmonary rehabilitation. These are the 4 outcomes that should be assessed and measured using validated strategies and tools pre and post pulmonary rehab, and if possible in follow-up as well. As you can see in this study, the 6-minute walk distance increased substantially, nearly twice the minimal important difference. And when the patients, a subset that were available for follow-up, were assessed at 6 months, there was continued improvement in functional capacity, actually at a very strong level, as well as continued quality of life and mood improvement. The Cochrane Review recently published a meta-analysis of 16 studies looking at pulmonary rehab, and they looked at a fairly broad set of patients and various ILDs. We know that pulmonary rehab needs to last at least 8 weeks for the patient to derive a clinical benefit, ideally between 8 and 12 weeks, and a frequency of 2 to 3 times a week would be an effective dose. The mean change in 6-minute walk distance beyond the minimal important difference, which is thought to be close to 30 meters. And IPF close in terms of the impact. Patients were assessed to have improved dyspnea and quality of life with a significant improvement in the St. George Respiratory Questionnaire. A group of patients underwent assessment at 6 or 12 months, and they had continued improvement in functional capacity. The Cochrane Review rated the evidence as low to moderate quality, primarily because of the heterogeneity of the studies. All of the findings found that there were no adverse events during pulmonary rehabilitation. Well, this study is hot off the press. My colleague Sabina Guler in Switzerland developed a important trial looking at survival after pulmonary rehabilitation and fibrotic ILD. This is a retrospective study of 701 patients, 12 sites in 5 countries, in the US, UCSF, where I provided rehab, and then also University of Alabama were 2 participating centers. So some important findings. There was clear improvement both with outpatient and inpatient pulmonary rehab when you look at the change in 6-minute walk distance. And so what they found was that 6-minute walk distance improvement during rehab was associated with a lower risk hazard, or I should say a lower hazard ratio for death or lung transplant. So a very important finding. One finding I'd like to highlight is that participation in pulmonary rehabilitation of the planned amount of visits, at 80% or more of those planned visits, is associated with a 33% lower risk of death. So I think a very important finding and not surprising. We think that this is what we would find, but now we have evidence to support it. Susan Jacobs did a very nice job of cataloging numerous studies looking at pulmonary rehabilitation and ILD and found generally consistent improvement in functional capacity, dyspnea, and quality of life, so further strengthening the evidence of the importance. So we know that rehab has an important role in this population. We should consider where should we target our efforts with the patient's goals really driving what we do for them? What do they value? Symptoms, increased dyspnea, hypoxemia, and oxygen needs, muscle weakness and skeletal muscle dysfunction, cough can be very disabling, mood abnormalities, knowledge gaps in terms of getting the most out of their care, and certainly last but not least, the importance of advanced directives. And where are the opportunities for leveraging knowledge and performance in the patient's favor? So as in all interfaces with patients with ILD, IPF, an accurate diagnosis is the important starting place. In rehab, at a minimum, we need high-resolution CT and a full PFT. Again, the important outcomes I mentioned that need to be measured to assess rehab effectiveness, as well as the important role of assessing and managing hypoxemia at both rest and with activity, targeting the patient's goals. We know that exercise is the cornerstone for pulmonary rehabilitation, and these are not the patients that we would say, well, just go to the YMCA and exercise. This patient population has clear physiologic abnormalities that need to be considered in the context of safe exercise. Rapid shallow breathing, often worse with exercise, impaired hemodynamics and gas exchange with VO2 mismatch, pulmonary capillary destruction may be present, as well as hypoxemic vasoconstriction and an increased risk of pulmonary hypertension, which in and of itself has risks during exercise. We see that on cardiopulmonary exercise testing, VO2 peak abnormalities, and exercise limitations. So all of these need to be considered. We start with regular ongoing assessment and gradual exercise progression, but within the physiologic parameters for each patient. Ioannis Vogatis did a really nice job of summarizing how we begin in terms of formulating an exercise prescription for patients with interstitial lung disease. The American College of Sports Medicine uses a FIT methodology. Frequency, intensity, time, and type are the 4 elements of an exercise prescription. So 3 to 5 days a week, 60 to 80% of peak work capacity for intensity for continuous exercise. Some will use a 6-minute walk test and calculate the miles per hour and a % of that for starting. Time, a goal of 20 to 60 minutes per session, but we often don't start there. Patients may be quite deconditioned and symptomatic and need to start at a more modest level. Aerobic and resistance training are both of great value in terms of all patients with chronic lung disease, including those with ILD, IPF. Outcomes I talked about. We really want to emphasize longer programs with more frequent sessions provide greater benefits across the board. So some other comments on exercise prescription. The training load should be greater than those experienced on daily levels for the patient. Both intensity and progression can also be assessed and considered in the context of symptoms. So an example would be the Borg 10-point category ratio scale. Using this scale, a goal of a goal of 5, so right about in the middle. 4 to 6 is a symptom level. However, if we're exercising them at home, we would use a lower level just from a safety standpoint. I don't know if you're familiar with interval training. This is common in elite athletes, but it certainly can have a role, particularly in patients with intolerable symptoms. So this might look like resting for 30 to 60 seconds and then exercising at a moderate level for 30 to 60 seconds with monitoring, O2 sat, heart rate, dyspnea, resting, exercise, resting, exercise. So if they can tolerate this, then, and it's at the same workload, they may derive the same benefits as continuous exercise. Stretching may have some benefits, but it doesn't have an evidence base in pulmonary rehab and should never be used at to replace aerobic or resistance training. Symptom management, having strategies to address this can be quite helpful. We know that physical conditioning has an important role as well as assessment and titration. A subset of patients will have improved dyspnea. For some, breathing retraining can be helpful. Pacing, more difficult activities, followed by rest or less difficult activities, and panic control, all can be of value. I want to comment on self-management. This can be a very important area for patients to build their self-confidence and achieve their goals through adaptive behaviors, addressing their challenges in the intent of being able to do what they want to do. So less advice on how to do it, more on experimentation with guidance and support to get to where they really want to be. The ATS published a clinical practice guideline on oxygen recently, and when we looked at the data when we were writing this, it was really challenging. There's very little good evidence about oxygen in ILD, and that limited our recommendations. We do know that for patients with ILD, if they have severe chronic resting room-air hypoxemia, they need to be on oxygen at least 15 liters a day. However, exertional severe hypoxemia or liquid, which has been challenged because of competitive bidding, the recommendations were suggestions because of very low quality evidence. We did strongly recommend patient and caregiver education on use and safety of oxygen. Where does virtual pulmonary rehab fit in? Before the pandemic, it really was not common at all in the US, except for an occasional research center. However, now we're seeing more and more interest in it because of COVID. Patients weren't so eager to return to the rehab setting in the center. So center-based is the best understood and established and has an evidence base of effectiveness. Virtual definitely is convenient, and there is greater pulmonary rehab adherence because of the convenience. So it has its role, but we have to be realistic about what we're recommending here. Some things to think about. We are delegating a great deal of self-assessment and judgment to the patient. Not every patient is a good candidate for this model to maximize safety and effectiveness. It needs to have all the elements of center-based rehab. Patients need to know their oxygen needs and how to manage those with exercise. No large exercise increases, just like in the gym, and know when to stop exercise and how to get help. They need to work with their provider, and they need to have a support group to answer questions. Finally, I'd like to offer some resources for pulmonary rehabilitation. This is a toolkit that we developed at AACVPR. My colleague Amy Kazart, UC Davis in Sacramento, and I and colleagues from AACVPR, providing patients some information about tools for rehab, especially if they're having trouble accessing it. These are two pulmonary rehab directories, the AACVPR directory, and then ATS has a directory called livebetter.org. And I want to thank you for your time. It's been a pleasure talking to you today, and I hope you enjoy the meeting. Thank you.
I'd like to thank you for the opportunity to talk about my research journey and inspiration. My name is Dr. Kathleen Lindell. I'm Associate Professor of Nursing in the Mary Swain Endowed Chair in Palliative Care Health at MUSC College of Nursing in Charleston, South Carolina. I have no disclosures. The objectives of today's talk, I'd like to talk about three things: program development history, my path of research, and the next steps to advance palliative care. So program development history. So this is a picture of me in 1978 when I graduated from St. Francis General Hospital in Pittsburgh, Pennsylvania. I was a staff nurse there in the medical ICU and then in the emergency department, taught in their diploma school of nursing for 4 years, and then became the nurse manager of their emergency department from 1986 to 1989. At that time, it was the largest hospital in the city of Pittsburgh at 750 beds, and it had a 250-bed psychiatric unit, and all those patients were triaged through the emergency room. So I really owe my roots of nursing to St. Francis because I saw so much and learned so much there. After receiving my master's degree in pulmonary nursing from the University of Pittsburgh, we moved to Wilmington, Delaware, and I worked at the University of Pennsylvania as a pulmonary clinical nurse specialist from 1990 to 2000. This was in the Penn Lung Center, which housed many specialty programs. This was also the beginning of ambulatory care in the 90s. We only had patients in the morning clinics. We shared the clinic space with rheumatology. When I started in 1990, I think we had 3,000 visits per year. And when I left in 2000, we were up to 13,000 visits. So ambulatory care was taking off. While I was there, I worked as a clinical nurse specialist in this center, but there were a few special programs that I worked with. So one was an allergy and asthma program to reduce hospitalization for asthma flares. We brought patients discharged earlier from the hospital and brought them into a specialty clinic, and we did reduce readmissions. I also worked with the adult cystic fibrosis program for 2 years, where we transitioned adult children or children who became adults with cystic fibrosis from right next door at Children's Hospital to our adult care outpatient practice. And then my last 6 years that I was there, I directed the Penn Quit Smoking program, which started for patients who wanted to quit smoking and then progressed to employees and students on campus. And it then became the tobacco cessation program for the health or the entire health system. In 2000, I was recruited back to Pittsburgh, to the University of Pittsburgh, to the brand new Simmons Center for Interstitial Lung Disease. And we were, a very generous donor gave money to start this center. And he had 3 charges: find the cause, find the cure, provide patient education and support. So my role was number 3, to provide patient education and support. So I would be in the clinic when we saw patients. I'd do their history before they had were seen by the physician, and then do their follow-up care. In addition, at the time, I was directed to start a patient support group, which was just a fantastic experience and really grew over the next 20 years. So I'd like to start and tell this story about Frank. If you've seen this before, it bears repeating. So we all take care of patients with IPF and now other types of progressive pulmonary fibrosis. And the patients often report that IPF comes out of nowhere, and they have difficulty they and their caregivers recognizing the disease magnitude. We know that the disease progression varies per patient, and we also know that survival is probably 3.8 years, but that varies per patient. So in this picture on the right, this is Frank. Frank was one of our patients who had IPF, and he was so proud of himself because he has his e-tank connected to his gas lawnmower, and it's at 15 liters per minute. And he was pretty proud of that and brought that to Pulmonary Rehab, who quickly guided him on the safety issues of please never do that again. But in this picture, if you fast forward 2 months, Frank was in the hospital with an acute exacerbation on ECMO, and he did receive a lung transplant during that hospitalization. This next picture is Frank, and this is 8 months later with 2 of our other post-lung transplant recipients at the annual Violet Rippey Walk. And this just showed to the success of Frank. And so I'd like to now just expand upon IPF. So we know IPF is associated with a shortened lifespan, a variable disease course, tremendous symptom burden, impact on caregivers, limited treatment options, a need for supplemental oxygen, and a need for palliative care. And overall, these patients and their caregivers experience a poor quality of life. On the right are just a few of the studies that share this information. So there are several possible disease courses for patients with IPF. And if we take a look at this, along the x-axis is time in years, and on the right axis, or the y-axis rather, is disease progression. Lay reported this in 2011 in the Blue Journal. So often there's this subclinical period where patients have the disease, the disease onset, and before they're even diagnosed, they have symptoms. And then by the time they get to diagnosis, it's often their disease has taken off and is progressing. And so there's variable disease courses. If we take a look, the one that is with the stars, this is a patient that has a decline and has an acute exacerbation, has a really precipitous decline, never recovers, continues to go down, and then has another decline. And so it's very difficult to predict the disease course for these patients because we don't know how the individual's disease will advance. We do know that patients experience a myriad of symptoms. And so this is from Van Mennen in Optimizing Quality of Life in 2017. And I think this cartoon is really very nice. It talks about the myriad of symptoms that these patients experience. So dyspnea, cough, fatigue, deconditioning, depression, anxiety, all of those impacting quality of life. So when I returned to Pittsburgh, a year after I was there, my advisor from graduate school asked me, when are you going to go back and get your PhD? And I said, I was thinking about it. And the next day, the application was on my desk. And within a few months, I was started back to the University of Pittsburgh in their School of Nursing for my PhD in nursing. Now, I need you to know along the same time, I was working full-time. I needed to work full-time to get the benefit to cover school. And I also had a growing family. I had a third and a sixth grader and my husband. So this really was a family-centered degree. I did, luckily, the school was right across the street from work. I had an extremely supportive boss and mentor who wanted me to attend. And luckily, classes were late in the afternoon, so I could walk across the street. It took me a total of 6 years to finish to get my PhD. But when it came time for my research question, it came very naturally. It was, what is the disease impact of IPF? As I said, I did the histories on these patients, and I could tell that, oh my, this is not going to bear well. And then I'd see the patients go in, have their visit, come back out, and they would kind of have a blank stare on their face. And I thought, I wonder if they understand and appreciate the disease magnitude. So I did a pilot study, and I regret that I never published this pilot study. But what we learned in 28 patients with IPF, that over half, 57%, were depressed. And if they had good quality of life or good support or good social support, they had good quality of life and vice versa, which makes perfect sense, but it was never really presented before. So that led me to do my dissertation, which was published in Heart and Lung in 2010. And we did a disease management program on symptom burden and health-related quality of life in IPF patients and their caregivers. And so this was a 6-week course where patient and caregivers were randomized to receive the course or receive usual care. And we had 10 patient caregiver dyads in the intervention arm, 11 in the usual care arm. And so we looked at symptom burden, which included depression, anxiety, and dyspnea. We looked at stress and health-related quality of life. And what we found was that patients had an improvement in stress, but caregivers had a tremendous improvement in their stress. And remember I said I was a educator in the past? Thank goodness, because I did surveys at the end of the session, and every patient and caregiver wrote, everyone who gets this diagnosis should have to take this course. And so my mentoring team said there's something in that. So it led to the second part of my dissertation, which was a qualitative study where I went and did home visits in Western Pennsylvania. So this is a map of Western Pennsylvania, and you can see the red circle around Pittsburgh, which is starred. So I did a total of 10 home visits across Western Pennsylvania, and it was one of the most enlightening times of my career to go into a patient's home and to see how they live. And, you know, when you think of where you live in your geographic region, there's different types of homes. And so in Western Pennsylvania, it's a hilly area. And I had patients who lived in houses that were 2 stories, and they had to navigate oxygen upstairs, downstairs. I had the very last visit that I went to, a patient had 100 city steps to get to her home. And I thought, how does she get up there, let alone the oxygen delivery person? So it really was very helpful to me to kind of like step out of my comfort zone and see what they had to go through. And what the patients said was being in that course really was impactful for them because they got to see other patients who had the same disease. And it gave them a perspective of who was sick, who wasn't sick, what their future might be like. And they said that when they go home to their communities, no one knows what IPF is. And they might recognize the word fibrosis. And so they would be like, I thought cystic fibrosis, I thought that only happened with kids. And then the major finding was that there was significant decrease in stress in the caregivers. And when we teased that out, they said that they now knew what to expect moving forward. So then I graduated and continued to work as the clinical nurse specialist and would go with our medical director to the ICU. And I saw that there was often a lot of anger from the caregiver that you didn't tell me my loved one was going to die. And I knew that those conversations happened, but I realized that there was some kind of communication mismatch. So one of my mentors, Randy Curtis, said, you need to tease out the data. So we did a retrospective study and looked to see where every one of our patients with IPF died and if they had a formal referral to palliative care. And this was published in Chest in 2015. And so the study sample, we had 465 decedents. 61 had transplants, so they automatically are out of the group. And then we could find known location of death for 277, but we couldn't for 127. And think about those patients that come to see you and they only have one visit, and then you never hear back from them. So what we learned in this experience was from diagnosis to death in our sample was a 3-year median survival. And first center visit to death was the median length was 1 year. And so on average, there was a 2-year delay from diagnosis to initial evaluation at the Simmons Center. And this was repeated at other centers across the United States. And you may see that at your own center. What we also learned was ICU admission happened early for 34%, and that was after their first visit. And so, that serious nature of the disease was not always able to be impacted at that visit. We then did a study where we did focus groups on patients, caregivers, and caregivers of decedents to find out what they thought about palliative care. And in these focus groups, they were separate for the patients, caregivers, and their caregivers of decedents. But the four themes that emerged were there was patients felt like they had a need for education and weren't receiving it. The symptoms were very impactful, especially for the caregivers. They didn't really know what palliative care was, but they didn't like the term because it was scary. But they took comfort in the specialty center because of the resources and the other people that they met through support group. As a sidebar, I also am very active in the American Thoracic Society, and Susan Jacobs and I were talking at a meeting back in 2015 about the change that we were seeing in our patients receiving supplemental oxygen. So we then went on to do this survey of almost 2,000 patients with different lung diseases. And this was out of the nursing assembly of the American Thoracic Society. And it's great to see how this is kind of like advanced. So this was the first study, Patients' Perceptions of Adequacy of Supplemental Therapy. And this was in the Annals of American Thoracic Society. And then I did a sub-study here and the qualitative components and found that when we looked at the data for the key concerns and that patients were worried about their equipment, access, and they were worried about running short of ice or oxygen. But the main thing that really came out was these patients were becoming socially isolated because of their need for oxygen therapy. And I'd like to applaud Susan Jacobs and the group because they've really advanced this, and the ATS now has oxygen guidelines for the first time that these are international guidelines to address. And so there's a lot of good work that's being done in that arena. I had a fellow join me, and he expanded upon that initial decedent study, and this was reported in Journal of Palliative Medicine. He advanced it for a total of 3 more years for a total of 16-year study. And what he found was that palliative care referral recipients had less in-hospital deaths and more in-home and hospice. And this was when they were referred. And those patients, this is really very important to me, those patients who attended at least one support group meeting received more palliative care. So my current research, I created this book called A Program of Support. And this is the protocol paper. This was published in 2018. And this is a copy of the book. So this is based upon my clinical experience. The acronym is SUPPORT, Symptom Management, Understanding the Disease, Pulmonary Rehabilitation, Palliative Care, Oxygen, Research, and Transplant. All things that through my clinical experience I thought were critical for patients and their caregivers to learn about. So I received funding from the National Institute of Nursing Research to do a K-23, and that the goal was to determine the feasibility, acceptability, and efficacy of an early palliative care intervention compared with routine care in patients with IPF and their caregivers. Our hypothesis was that early introduction of palliative care would improve knowledge and preparation for the end of life, patient-reported outcomes, and advanced care planning in IPF patients and their caregivers. This was a randomized controlled trial with patients in an intervention arm and a usual care arm. We recruited 76 patient caregiver dyads over 2 years and 9 months. It took us a little longer than we had planned, and the patients were diagnosed with IPF in the past year. And the study visit was aligned with 3 clinical visits over a 6 to 8 month period. What we found was that feasibility was limited. There was high attrition. 39% of the participants died or were transplanted before the study was completed. Remember, this was in an 8-month period of time. So it just, lends to that, that disease course that is unpredictable. We also had a lack of diversity. We had 100% white participants, 85% males, and 15% females. The intervention was acceptable to both groups, and the initial impact or efficacy demonstrated that patient participants noted improvement in knowledge and improvement in advanced care planning completion. Caregivers and participants noted a significant improvement in knowledge, disease preparedness, and confidence in caring for the patient. This was recently accepted for publication in the Annals of the American Thoracic Society and will come out in print in November. So the next step is literally this morning, I just submitted an R01 expanding this nurse-led palliative care delivery via telehealth in progressive pulmonary fibrosis. And then I'd like to thank the National Institute of Health, National Institute of Nursing Research for funding my study, along with Three Lakes Partners and the University of Pittsburgh Dorothy P. and Richard P. Simmons Center for Interstitial Lung Disease at UPMC. So future directions. In 2020, we expanded support to Support C to patients with advanced COPD and are getting ready to study that in a community support program in Pittsburgh in a community pulmonary practice. And this is to promote palliative care among community-based patients with advanced lung disease. And this is led by Sarah Klein. She's a DNP student at the University of Pittsburgh, and I'm a co-investigator. And she just received funding from the Hoffman annual grant to provide payment for patients to participate. I'm also involved with a postdoctoral student at the University of Pittsburgh looking at neighborhood disadvantage and air pollution on clinical outcomes, and that's funded by Boehringer Ingelheim, and I serve as a co-investigator. I am working at the university, as I said, at Medical University of South Carolina, and I'm working with a junior faculty who has expanded the support intervention to Support D to study this for patients with Alzheimer's and their caregivers. And she's part of the MUSC KL2 Scholars Program and has funding for the next 2 years. And then, as I mentioned, I submitted a randomized controlled trial of telehealth delivery of nurse-led palliative care in patients with progressive pulmonary fibrosis and their caregivers to NINR as an R01 due in October of 2021. And then a future study, we would like to explore expanding an ILD nursing curriculum using this program of support. I want to report on the when you do one of these interventions and invent something. So we worked with the University of Pittsburgh Innovation Institute, and this is copyright registered. And there's an intervention patent that has been submitted. And we have done this several times, iterations to get it to its current state. So this was the original, or this is the current form of a program of support. So in my current work, I'm at MUSC, and I also work with the Advanced Lung Disease. And here we are going blue up for Pulmonary Fibrosis Awareness Month. And then my new job, I work as a endowed chair and really to advance palliative care education. And all of our students at MUSC College of Nursing receive undergraduate and graduate training in palliative care. And we have the first program, a DNP in lifespan palliative care that opened in 2020. So with that, special thanks to our patients who helped to guide us. And this patient in particular who said, you know, when I got this diagnosis, I realized that I really need to move forward and do the things that I want to do. So thank you.
Wow, what a wonderful ending to the non-programming at the PFF Summit 2021. I can't wait for us all to be back in person in 2 years. Susan, your expansive knowledge on oxygen and the access to oxygen is so vast. Thank you for sharing some of it with us today. Charlie, what a wonderful overview and practical suggestions when managing patients on antifibrotics. Lung transplant may be a part of the journey for many of our patients, and Rebecca provided some wonderful take-homes and takeaways on that workup process. Thank you. Pulmonary rehab is such a critical resource in treatment for patients living with PF. Chris, you shared so many important reasons and evidence-based reasons why pulmonary rehab is so important. Thank you. And Lise, thank you for sharing and expanding our knowledge on pulmonary hypertension and autoimmune ILD. The pictures of the rashes were very helpful for me, as I'm sure many in the audience. Kathy, you are such an inspiration for all of us. Your story is just so remarkable. Not only what you do for your patients, but how you educate all of us. And you're just selfless sharing to us continuously within the non and the care center network and more globally at the PFF. Thank you for all that you do. To our audience, I hope you enjoyed the 2 non-sessions as much as I did. I'm ready to keep learning and engage with you on our working groups and get working on the newly released PFF strategic plan. Please connect with me, Jamie, or Janelle to join a working group. You will be receiving a survey about this year's summit on Monday. Please take a moment to fill it out and share your thoughts. We highly value your feedback and will use it to guide the development of our next summit. In closing, if you're interested in chairing the non-sessions for 2023 when we're in Orlando, fingers crossed in person, please reach out to me at jshore@pulmonaryfibrosis.org. Again, thank you to all of our speakers over this wonderful week.